Hello, everyone. Welcome to Lactation Education Resources presentation of Nikki and Nikki. Our presentation today is Breastfeeding, Equity, and Pandemics. Oh my! Emphasis on the oh my. So thank you
Mhm.
all for joining us today. I will let Nikki and Nikki introduce themselves. We're just very honored that they are here with us. If you would like to see previous episodes of the Nikki and Nikki webinars and information about COVID-19, they are all found free on our website, lactationtraining.com/COVID 19. We also have a whole bunch of other resources there, including all of the handouts that Nikki and Nikki have helped us to create. So without further ado, I'm turning it over to Nikki and Nikki. Hi.
Hello. Thanks, Angela.
Hello.
A warm
Thanks, Angela.
welcome. All right, I'm Nikki, Nikisha Killings, private practice lactation consultant in Los Angeles, California, for like just a couple more episodes, and I'll be live from someplace else. Stay tuned. And that's why you'll see my lovely mattress. Don't mind that backdrop there. Moving. I also am director of equity and equity and inclusion with Lactation Education Resources, and one half of Nikki and Nikki Lactation Career Consultants. And this is my lovely other Nikki. That's weird.
I'm
Yeah,
like,
y'all get
what
it.
am I?
The partner.
um,
Yeah, yeah.
Thank you, other half partner. Hey everyone, I'm Nikki Hunter Greenaway. I am the other half of Nikki and Nikki, the other Nikki. I am a family nurse practitioner and an IBCLC in New Orleans, Louisiana. I have a private practice where I do prenatal, postpartum, and lactation care. I primarily do home visits. I have halted home visits, but it's funny we talk today because today I'm doing my first home visit. Today I'm going back to the shelter, to the homeless shelter that I contract with to provide some care. So it's a big day for me and also for this topic because it directly relates to this topic of equity and pandemics and how people are being left behind and stuff like that. So, hello everyone.
Yeah, hello. So this is a topic that's near and dear to both of us because we both do home visiting in the community, and both of our practices have a lot of focus on underserved communities and folks
Mm-hmm.
who are directly impacted by inequities in lactation support and inequities in healthcare in general. Um, Interestingly enough, as it relates to this particular pandemic, the places that we live, Nikki's in New Orleans, I'm in Los Angeles, as we've said, are handling this a little bit differently, and the numbers are reflecting as such. But before we
Right.
get into that, we will check in. How are you doing today, Nikki? And how is our
I'm
audience
good.
doing? Feel free to chat. Oh,
I'm good. I'm good today.
a, a simple I'm
Oh, what happened?
good.
Oh yeah. I'm good. I'm good. So one of the things that I've taken from these Q&As, and we've had different people on, is, and we reiterate this every time, but I think it's easier to speak it than to live it, of self-care. And during this time, because we can get so inundated. So Nikki and I are looking at facts all week, looking at different data that's coming through, listening to anecdotal stuff. We're dealing with clients, all that kind of stuff, and then we're on social media to keep our clients and everyone, our community, abreast of all the information, and it just really starts to weigh on you. So I
Yeah.
found it like extremely important to continue therapy because I was like, oh, I'll just do like every other week. No, I need to check in every week. I need to unload these bags off of my back and like be free of some of that stuff. And I can honestly say that now on week 8, I'm good. I'm good. I have a clear frame of mind. I feel like I can see the fog kind of clearing as far as what needs to be done, who's clearly being left behind. It wasn't just an oversight. It's a clear being left behind. That's my target. I know what I need to do. How do I protect myself? Things like that. So I can see a game plan forming finally after 8 weeks. So
I love that. I love that. That's probably, and if you watch back our videos, you will see the evolution of this. You will see us
Right.
kind of go from to now, you know what? Here we are. Oh, that's fantastic. I
Right.
would love to know if the audience is experiencing this as well. If you've come to a new place in your journey, in terms of how you're personally doing during this pandemic. I am at, I mentioned at the top that I'm in the middle of a move. So there are some,
Mhm.
additional stressors in my life on top of what's happening, and some additional stressors that are compounding kind of my anxiety around being in the middle of a pandemic and being in a city who's taking
Mhm.
it so seriously. And so, I don't know if I'm a simple good like Nikki is,
Got you. We're
but
gonna get you
definitely
there.
we're gonna get there. I'm definitely in a better place than I have been in some previous weeks, because some dust is settling on some things, and I'm able to, like you said, see the path forward. There's a lot of work in the path forward, but at least I can see it, map it out. So that's how I am. Thank you for that. That was good. Audience, let us know how you are doing. I hope that you all
Mhm.
are less anxious and more, resolved in terms of the path forward, like we are getting to, for ourselves. As
Right.
we mentioned, the topic is breastfeeding and equity in pandemics. And here's the thing, just like sunlight shines light upon things that may be lurking in the shadows, times like this really do highlight what's happening societally, what's happening in those parts of the community that we don't necessarily always hear from. It becomes glaringly obvious where there are disparities, and disparities in care lead to lack of loss of life. And so
Right.
that's where we are.
That's where we are. That's where we are. I looked at the numbers this morning in New Orleans, and as everyone knows, Louisiana has been hit really hard with this. Um, and I would say we have in the state we've had 1,200 new cases in the last 5 days. In the city of New Orleans, and then in the state we've had 453 deaths, and 340 of those 453 deaths have been African American. That's 75%. And so, and then I see the articles. Like I read an article this morning about Georgia and how rural Georgia is actually being hit harder than any other area in the United States. Just from whole families are dying, days apart because there are no hospitals there. So when you think about all these things like foundation type stuff of just like having a hospital, now you bring it up, lactation. Louisiana was already 49th in breastfeeding. Like we were already at the bottom. So just
Yeah.
thinking about the fact that folks are, leaving the hospital early, and then you think about the folks that are going to like places where I contract with, like homeless shelters. I have a mom there, and she's like, can you just bring me the ace bandage today? Why are we doing ace bandage? Because she's like, no one told me what to do when I'm dripping everywhere, so we just need to stop it. I was like, you didn't get any care. They like, well, you just gonna put your. She said, the lady said, I'm just gonna put my baby on formula anyway. Like we automatically assume that just because she was home, like so there are people that are being left behind. We're making these assumptions. There's implicit bias and explicit bias that is still
Yeah.
happening to a greater degree.
Yeah. So, we enter these conversations assuming everyone that is at the table has a certain base level of knowledge. But if this is your first introduction
Hmm.
to disparities in healthcare, allow me to enlighten for
Thank
real
you.
quick, real quick.
Take it away.
Um,
Take it
so,
away.
yeah. So there are rampant disparities, racially specifically in our country when it comes to healthcare, certainly socioeconomically as well. And Nikki mentioned some rural areas of Georgia that are really hard hit because of lack of access to care. Well, that access to care is compounded if you have black or brown skin in this country. And that is for a number of reasons. They range from environmental to economic to political, but they are what they are. They are not debatable. It is evidence based. The data bears out, no matter how you look at it, that the disparities exist because folks are not being believed, being listened to, being granted the same level of care as folks with fairer skin, period. That's it. So that's the baseline that we're working from, recognizing that that is a thing in the United States. It is a long-standing thing that's occurred, um, you know, for hundreds of years. It's as long as this country's been in existence, folks have gotten lesser care and lesser attention in a number of ways. But today we're talking about in healthcare specifically. So that is what it is. That's what we're working off of when we have this discussion, understanding that that's the situation. In a city like New Orleans or in a state like Louisiana, where 75% of the folks who are being impacted, who are dying, 75% of the people who are dying are Black. That is just. Do you have any idea what percentage of the state is Black?
I should probably know this, but
It's
I
not
know that New
75.
Orleans is saturated. Right. It's
It's not
not.
75. It's
I don't know
not.
if y'all looked
Yeah.
at any elections, but it's not.
Yeah.
That's not the case.
Yeah. So that's a glaring one.
So.
It has a lot to do with the way that the powers that be are deciding to approach this particular pandemic. Here's the thing. In
Hmm.
Los Angeles, I just read today that 6% of those who contract the illness, who test positive for the illness virus, are Black. 6%. That's well under the percentage of Black folks in Los Angeles, right? Only and people who are African American represent only 3% of the deaths,
Hmm.
which is remarkable. It's remarkable. It's a
Right.
shining example of how these things should look, right?
How?
And that speaks
Right.
tale of two cities here, ladies and gentlemen, and
Right. Literally.
individuals. Yeah, so this is
Hmm.
an example of the way that things can look differently has to do with how healthcare is being approached. So there has been kind of a really focused effort on making sure that underserved communities, the homeless in particular, they pinpointed it down to one particular shelter in LA that was a hot spot and tackle that one specifically. And there's been really, really focused efforts on making sure to identify where the issues are in communities that are often overlooked, to make sure that there are not disparities. I heard a couple weeks ago that Asian and Pacific Islanders were dying at a higher rate than they're represented in the state. That number is kind of washed now. There's been focused efforts on making sure, even though they were only about 1%, making sure that still they're not dying any more than anyone else is. And that has to do with, intentional moves to support
Right.
people in the way that makes sense for them, whether they have their housing compromised or food compromised or whatever their situation is,
Hmm.
finding ways to support them where they are in the way that makes sense.
Right. Intentional care. We do that with heart disease, and we do that with breast cancer. Like, we focus on the groups that are gonna die the most, and then we help improve it. And I know you know, we've heard people in the past talk about, well, if we focus on this group, then this group will start. At least I've heard this from hospital executives here, like, oh, Black maternal mortality. If we focus on Black women, then white women start dying. That's not how this shit works. It doesn't
It's
work like
not.
that.
Yeah.
Like, it's not a seesaw or something like that. Like, if we provide equitable care, you providing equitable care to everybody. That's
That's
the
really
whole
kind of what
concept.
equitable means. It's kind of what equitable means, right? So it means if everyone's seen the graphic of folks trying to look over a fence at a ball game. Someone's really tall,
Mhm.
they can see over it, no problem. Someone's, a little bit height challenged, maybe they can barely, get their eyes over the fence. They
Mhm.
can't see, and then someone's way below and they cannot see. All we're talking about is giving the guy who's here a leg up so he can see, the guy who's way
Mhm.
under here, maybe two boxes to stand on so they can see,
Right.
helping everyone to see at the
Exactly.
same level, but it is in no way ignoring the
Exactly.
person who could always see over the fence.
Who could always see. This is what I'm thinking of. So when and speaking about breastfeeding and how I have experienced in several occasions before the pandemic where mothers were like, no one even came in my room. They brought all this formula in there. My baby, I told them I wanted to breastfeed. The baby came back with tons of formula in their bed. And I'm like, okay, all right. So did we not listen to the mother? Well, you're going to need it. Don't worry. You're going to need it. Things like that. And I'm like, why is this happening to our Black and brown folks? Like, why is that happening? Why we make the assumption based on some statistics, which I think sometimes can be skewed because, I mean, if you truly we have to think about the definition of what breastfeeding means. When I've talked to some of my clients, they are pumping and they're like, oh, I'm not breastfeeding because the lady told me I wasn't breastfeeding. I'm like, no, you're
The
absolutely
lady
breastfeeding.
told you.
The lady
Yeah.
told you.
But think about
So,
that. Think
in,
about a provider
yeah,
working from a position of assumption that this family is not going to breastfeed and
hmm
how they may approach care
right.
based on those assumptions. Yeah, sorry to cut you off.
No. There's, I mean, it's happening throughout our entire community, and it's whether we have different skin or whether we're different socioeconomic status. I would say of all of my mothers at the shelter, at the homeless shelter, maybe, and I have 44 moms, like maybe two are breastfeeding because those are the only two that like they've received that care in the hospital and someone stressed it. I can't be at the hospital with you. So I can only get you from this end. And by that time, you've already probably made up your mind, but we can really, work on it and some relaxation and all of that. But the motivation needs to come, the education, that spark. I've prepared them as much as I could before through telehealth, but that touch that they got from the hospital, I really needed it to happen there.
I think that's a really important point that you make because that's a particular community that could benefit so much from breastfeeding, right? So they don't have to worry about
Mm-hmm.
how to afford formula, how to mix it in a sterile environment, any of that, if they only were able to be successful in breastfeeding. But
Right.
that starts with support, education and support that they're not getting prenatally at the bedside ever often, right? They're not
Mm-hmm.
getting it at any
Right.
point in the process. So it's the reason why there are only two people in that shelter who are being successful is not because there are only two who wanted to breastfeed. There are only two who were
Right.
well supported. And that's what we're talking about
Right.
today. Uh,
Right.
Angela, please let us know if you have questions from the audience. Audience, let Angela or chat if you have questions, comments, want to contribute anything. We want to hear from you as well. But yeah, let's dig into that a little bit. So, what does it look like to support a community? To support your community, knowing there are underserved groups who are being ignored, overlooked, rushed through the birthing process, some for good reason, right? They got to get them out of the
Mm-hmm.
hospital so they don't get exposed to COVID-19. We get it. But what does that look like? How do you support families who, or even find them? What can you do to support your community at this time? Nikki,
Right.
thoughts?
So I reach out to community organizations. That's what I've been doing. I've been contacting shelters. I contacted the health department. I was like, hey, so what's happening to the homeless folks? And they're like, oh, I don't know. Like, we'll send your number to them if they need anything. But they're so inundated with so many other things. I'm like, I'm going to contact them myself. Hey, these are the services that I have available. We can try and set up, in which I had already had a contract prior to this. So it wasn't that hard to get it. But other shelters, they're like, oh, I don't know. Will our clients be interested in that? Hey, don't marginalize them. Like, don't cut them off from resources even more than they already are.
Yeah.
So I have been doing a lot of the, phone calls, cold calls, and all those type of things, just putting it out there and just putting it on social media like, hey, we have these issues. Another thing is, they've been doing monitoring at home. I don't think a whole lot of guidance has been given to pregnant folks. None whatsoever, as far as which prenatal appointment I'm supposed to go to. Am I supposed to get this done? Am I supposed to? And so we're seeing an increase in inductions, increase in sections, and an
Yeah.
increase in NICU babies. Our NICUs are full. So we really, and then there's no blood pressure cuffs. Like, how do you supposed to monitor their blood pressure if no one ever gave them a blood pressure cuff and Medicaid is taking 2 months to ship a blood pressure cuff? So contacting the foundation is Preeclampsia Awareness Month. Hey, Preeclampsia Foundation, they contacted me. We got 300 blood pressure cuffs. Now it's a matter of giving them out to the individuals. We got breast pumps now. WIC, I love them, but they're taking a minute with the breast pumps. Lancino, we got 20 breast pumps that I can give out. So I'm contacting the people, going straight to the source of all these issues and the source of the resources that I need. And it doesn't matter that, I'm a healthcare provider or anything like that. You're a community person, you see a problem, you go to the source of where you think someone can help you
I think that's
because
a
you already
really,
know
really
the
excellent
problem.
point. It's about being proactive. So you know your community
Right.
best. You know where the gaps in care exist. It's up to you to fill the gaps. If not you, then who? who was catching these
Right.
families, right? So I think
Right.
that's an amazing approach to just call up the organizations that are serving some of these communities and say, hey, how can I best support you? What do your people need?
Mm-hmm.
That's a
Right.
key in serving communities that are often overlooked, is asking them how they can best be served. They know. They can tell you, rattle off a list immediately. This is what the
Mm-hmm.
families need. This is what they're not getting. And then you can figure out how your care can best fill those gaps. That's an excellent way to go about it.
Right.
I would agree. Yeah, I think another thing that I would mention is if you have families who you've seen recently, um, through virtually or not, however you've seen them in the last couple of months, and you haven't heard back from them, I recommend reaching out. And because
Mm-hmm.
these families are used to often being forgotten, right? And so they're used to a practitioner seeing them one time and then never checking back up and asking how things are going and how they, how can I help you? Are there any humps I can help you overcome today? That alone, reaching out and asking that question, may help to save a breastfeeding relationship. And they may never have thought to call you because one and done is kind of what they've been used to getting, if that.
Mm-hmm.
Um, and so I recommend that. I'm going back through my logs of who I haven't heard from that mom, and I know we finished. I know we wrapped things up. She said she was good to go, but I'm gonna reach back out, just make sure there's not something else going on there that I can support her in. And then
Right.
social media, like you said, is another great way to really find folks who need you. Um, some of you out there probably in communities where you have a good relationship with the hospital. They're letting the families go
Mm-hmm.
really quickly, but they have record of
Really.
who was there. So if they won't let you kind of reach out directly to the families, perhaps they'll let you drop a brochure or a flyer into their
Mm-hmm.
outpatient packet or something to let families know once you get home, if you need help, I'm here to support you. And that may
Right.
be the difference between winning success and not success.
Mm-hmm.
What do you think, Nikki?
Very true. Absolutely. Absolutely. The brochures, all that reaching out, because these lactation departments, I promise you, they're still getting calls about outpatient services and people not, not knowing what to, they're probably getting even more calls. They're like, I never even saw lactation when I was in there. Like if you gave birth at home and had to be transferred to the hospital from just giving birth at home because you were afraid maybe to go to the hospital, you're only going to, and here in New Orleans, you're only going to be there max 6 hours. That's it. So I promise you, they're not going to be worried about lactation. They're not going to even think to put that in a chart like, oh, this person needs to see lactation. Like
No.
everything is happening so quickly. Whether you have a C-section or a vaginal delivery, you're going to be in and out here in 24 hours. They're getting you out. Um, so, so yeah, like it's not been a priority, and we know it's a priority. Therefore, we have to take it that step. So all these people aren't falling in the cracks, and they're getting all these phone calls, and they're probably sitting there like, I wonder. Well, I don't like they don't have like maybe a sheet to hand them of outpatient lactation services that they've set up. Our hospital set that up literally the week before COVID broke, and she just happened to be doing it. That's the only reason why they have it.
Yeah, I happen to be on a couple of resource lists, and so that's how hospitals or patients are able to find me after they discharge. Sorry, I'm reading a note from Angela. Okay, please feel free to drop questions and comments in the chat if you have anything for us. We're wide open, all ears, and happy to engage with you today on this particular topic or other topics that we've covered. That's fine as well. So yeah, I can't stress enough how important it is. I want to make sure I put a pin here. We talked about the baseline of knowledge and information that we're working from. Why is that important? Well, right is right. That's part of it. But also the families, the communities that are least served in our country, in the United States of America at least, are those who could benefit the most from breastfeeding. Both birthing person and baby are
Mm-hmm.
more likely to have any number of health issues, many environmental, many having nothing to do with their own health behavior, but they're likely to have asthma, more likely to have asthma,
Mm-hmm.
more likely to have hypertension, more likely to have, all sorts of things, obesity, in all these conditions are best served, by having a baby have mother's milk, right?
Right.
Point blank, that's it. So breastfeeding can save babies' lives. That's why we want to focus. And I'm sure you all know this already. You know, you all are used to touting the benefits of breastfeeding and why it's important to your community. Well, know that it's even that much more important to underserved communities because they already have a number of health disparities based on factors that are beyond their control. Many are beyond their control. So the more milk the
Right.
babies get,
We
the
touched on
healthier
it.
they're. Yeah, go ahead.
Yeah, we touched on it a little bit last week in relactation and talking about like milk banks and how here milk banks is so much money. Like it's so much money, and that's one thing a lot of folks right now don't have a lot of. So if they're really trying to feed their baby, but then they can't afford the breast milk, it's going to push them over to starting formula. And if insurance isn't paying for it, Medicaid doesn't pay for breast milk, then again, they're being forced just solely based on the fact of socioeconomic status. And that
Yeah,
should not be a factor. Socioeconomic status should never be a factor in regards to who can breastfeed and who can't, or who which baby receives breast milk and who doesn't.
yeah,
So there is a lot of underground milk sharing going on, and kind of rightfully so. Like you can't charge me $4 an ounce for some milk. That's a lot of money for a
yeah,
growing baby.
yeah. But people do it every day, right?
Mm-hmm.
So this issue is complex and it's multi-layered, and I can predict a question. I'll predict it looking at my crystal ball today. So we have listeners right now, both live and those who will catch this recorded, who are not people of color. And they want
Mm-hmm.
to know, what can I do to support families if I don't necessarily look like them? How can I be the best support? Does that matter at all in providing care to underserved communities? What do you think, Nikki?
First, being checking yourself. That's what I tell everyone. You have to check yourself in any situations that you approach. You have to check your biases and check where you're coming from. Check your privilege. Do a privilege check of all the privilege that you could bring to this conversation and corrupt it, right? So doing a check of that, and then just being open and honest about your care, and being attentive and listening. And that's when once you check your privilege, then you can come and you can give the care that you're supposed to be given in the first place. um,
Yeah.
so so that's why I think anyone that isn't Black or brown, just to check your privilege first and check, you know, will this be like, play it in your head. Don't let it come out yet. Play it in your head first. Like, what does that sound right? If I were to say that to someone, um, things like that. So yeah, and meeting the patient where they are. Don't make assumptions. Um, what I've been told as a child, assumptions make an ass of you, ain't for me. All right, so don't make assumptions. Just be clear and direct, and have compassion.
I would agree with all of that. The only things I would, expound on, I guess, not even add because you covered them all, is, if you don't necessarily look like the communities in which that you're trying to support, um, checking privilege, of course, first, but you also want to make
Hmm.
sure that you um, are really honest about where you are challenged, where you still have room to grow. And so I talk about
Yeah.
this quite a bit when I'm trying to support families that are non-gender conforming. And there's a little bit of a barrier there, or a learning curve for me, in terms of, making sure I'm saying the correct pronouns and making sure I'm supporting them in a way that is appropriate. And I often say, I'm learning here. I appreciate your grace, your patience. I want to support you the absolute best way I possibly can. Please help me. Please correct me if I say something wrong. Please help me with my language. But please know I'm trying. I honestly, sincerely want to provide you the highest level of care that I can. And I'm going to do that every step of the way today. And I, work to make sure we establish trust in that way, so they know that I am fallible. Absolutely. I
Hmm.
will screw something up in this process, but it is certainly not going to be my intention, because my intention is to give the best level of care that I can. And I'm going to continue to
Absolutely.
do that throughout our whole interaction. The best way to do that is to listen, and then, you with me? Believe them. I know.
Mm-hmm.
Sounds too easy. Sounds
What
too
you
easy.
say?
Be-
Right.
When
Say it one
people
more
tell
time for the
you,
people in the back.
don't just listen. Don't just listen. Believe them when they tell you what they're experiencing. And that's where we often
Mm,
fall short, right? Oh, well, I know this parent said that their pain was about a 10, but she didn't even look like she was in pain. It was probably like a 5. She's exaggerating. No, believe her. Believe
right.
what they tell you. That's the only way to get to the root of what they're experiencing and to solve the
Mm-hmm.
issues that they're facing is to believe the words they say. That's the most important thing you have in the interaction is what they are telling you with their body, with their words, mostly with their words. All right. Oh, we got 2 questions and 2 comments. So I wanted to stop there and make sure that we address that one because I had a feeling that some folks are quiet and not comfortable asking that question. But if you don't look like the folks you're serving, you certainly can still be a resource. Sometimes in a different way than I could be a
Mm-hmm.
resource to them. You may have some contacts, you may have some privilege that you could apply to the situation to help them a different way that I
Right.
can. So we won't be the same type of provider, the same offer the same care, but we certainly will offer care both you and
Right.
I, to those families um, audience. So, Angela, hit us with what you've got, and we'll continue to elaborate on this.
Okay, good. Thank you. So we have one comment from someone who's in rural Georgia. There's no hospital in their county. The nearest hospital county is in one of the top 5 hotspots in the state. So this
Mm-hmm.
person doesn't have any question, but the parents, she's just sort of supporting you when you say the parents don't want to go to the doctor because they are afraid of exposure.
Yes,
Yeah, yeah.
absolutely. Absolutely.
Rural Georgia was hit early. I know this person can expound on this way better than I can, being so far away from Georgia. But I know there were a couple in rural Black communities. There were a couple of funerals that really lit a fire before your
Mm-hmm.
local governments were taking this seriously enough to tell folks to stay home. A couple of large gatherings. I believe there were 2 funerals that really spread like wildfire through a couple of communities that was devastating, and the effects of it are still being felt. And those, unfortunately, some of those are folks who don't necessarily have the access to the highest level of care. Their hospitals are far away or understaffed. You know, they're looking like some
Right.
of these larger metropolitan areas. And just don't have the capacity to support families the way that they need to be. So our heart goes out to you as a supporter, to your
Mm-hmm.
community and what they're experiencing. And I surely hope that we are on that you're on the other side of it, that you're over the hump and getting closer to the end of that thing. Wow.
So this person is saying, also just commented again and is saying y'all are doing a great job. Only 2% of the population in her county is African American. How can I help? I'm in Northeast Georgia. The funeral was in Southwest Georgia. There's a big hospital there. So, again, to your
Mm-hmm.
point that you were saying earlier, Nikisha, how can I help?
Thank you for expounding that the funerals were in a different part of Georgia than you were referencing. And
Mm-hmm.
so there's issues in pockets of every state. Some states, some of us, listening on the call, may be in parts of the USA that are, hardly hit at all. Don't even like
Mm-hmm.
if you watch social media commentary, you will see there are
Mm-hmm.
folks who just really don't even believe this is a thing because they don't know anyone who's been
Mm-hmm.
impacted. They haven't seen it hit home yet. And so, there's parts of the world who are still in that space, and then there's parts of every state that are being impacted disproportionately and are feeling really isolated because they don't have the resources to protect themselves. And so, thank you for clarifying the facts there. Yeah, I agree. Um, Nikki, what say you to the person whose population is only 2% African American?
I will say, um, this is your space and you know your community. Where is your community getting their information from? And as we know that Blacks are at a higher risk of dying from this. And one of the things that the periodontologist contacted me a few weeks ago, and he's like, "What are we telling our community?" And I was like, "What?" He's like, "What are we telling? What is the message that we're telling our community?" Because as we know, there's some culture that goes along with this, with our sometimes the Black folks in trust of a healthcare system, trust of doctors, trust of that. So if you're you are the trusted word in your community. Make sure that we're getting the message out. Regardless of percentage, we don't want that percentage to be anything less than 2%. After all of this is over. So let's talk about the message in which, how are we getting, what is the messaging that is getting out to the community, saying that this is real. One person said that, well, Nikki, you have a voice in your community. You need to come out with a PSA for the community and saying, hey, yes, we did say, everyone stay at home. But if you have these symptoms, you need to get them checked out. Just like with prenatal care, we're getting no guidance on prenatal care. So yesterday I posted, hey, prenatal care is not canceled. You still need to get some prenatal care.
Yeah.
So, and
Yeah.
then folks are like, oh yeah, that makes sense. So look at the messaging, figure out where your community is and how you can get the messaging to that community.
Yeah, I would say, along with the disparities that exist, you should also note that the folks who are more likely to work in the jobs that are essential, that are still going to work, still your grocery clerks, still your gas clerk or whatever, are people of color. And so that they're facing the challenge of having to constantly be in the community and be exposed, but also be underserved in a way that's dangerous. I'll say that. To the person whose community is only 2% African American, I would wonder if you have a larger ethnic group that's underserved in your community that also needs support. I'd note if there are African American lactation supporters in your community who are already serving that 2%. It would be a great time to partner with them and ask them how you can best support them and their needs. Reach out. So those are two things that you could do, and continue to start to really acclimate yourself to those parts of the community that you maybe haven't before. Reach out in ways that you haven't before. Try to be innovative in this time to make sure your services are known, so that folks can reach you, and make sure that they are accessible. If your services have just traditionally been $200 an hour, in a time where folks are out of work or underworked, this might be a great time to have a special a discount code for people who wouldn't traditionally be able to access your care. So I'd offer that as well.
Yep.
One quick
Anything else,
comment about
Angela?
that is the person then came back, and I had a feeling this person is dealing with Appalachia. So they're in
Okay.
Appalachia up in Georgia. So indeed, I have seen in Appalachia where you've got 98% people who are identifying as white, and they've been there for many generations. And so it can be a challenge if you've only been there for 2 generations to to really serve the community. And so yes, though all of your suggestions are valid, where you just make yourself known and let people know that you're there and what your expertise is and how you can serve and support the community. So all
Yeah,
good things.
I'll give you this one for free. I usually put it in my paid lectures. So it's important to be known as a trusted agent in your environment, in your community, whatever that looks like. Often that requires partnering with the folks who are already doing that work and who are trusted agents. And so you yourself ought to be trustworthy first. Make sure the community should trust you in their care, which means you have to continue to educate yourself and expand yourself to be comfortable serving every person, and then partner with folks who are already indeed trusted agents in the community to provide the care. You may not be able to do that on your own. If you are newer, if you're considered an outsider, it may take some really strategic partnerships before you are able to be accepted and be listened to and be trusted. Note that that takes time.
Exactly. Absolutely. This is a time for collaboration and not competition. So we all have to work together.
Right. So good.
Say
So
that.
another comment.
Time for
Another
what, Nikki?
comment
What'd you
here.
say? Collabs, like what we're doing here today with LER and Nikki
Oh,
and Nikki.
absolutely.
Now is the time for collaborations to provide resources that are accessible to all. Sorry,
Yep.
Angela, what you got?
No, that's perfect. Thank you. So someone is saying it's very similar in New York City. And when you were talking about how parents are being discharged so quickly, parents are being discharged with very few instructions on feeding, and the pediatricians are discouraging them from coming in. when I followed up and I said, what are the pediatricians then doing as far as, following up with these families to provide care? The person said just recommending formula and saying all kinds of things.
Yes, I have heard that specifically from New York. I had a family contact me last week from Brooklyn, and they were talking about, we're just having a very hard time breastfeeding. And I said, well, I know I have a sister friend up there, and she's doing home visits, and she's like, I just don't want to do, why does it sound like so crazy when folks say, I just don't want to do formula. And so, the pediatrician's like, well, I don't understand, it's totally safe and totally fine, but she wants to breastfeed. So I connected them. They got a home visit, things like that. So people, yes, I think there's been very little guidance, like with obstetrics, with pediatrics as well,
Yes.
where folks don't know when to do their. Am I supposed to come get my 4-month shots, or am I not getting my four? Like what is essential care? So I think that is something that hasn't been addressed. Is we know who our essential workers are, but what is considered essential care? Am I supposed to go in and continue to get my mammogram? Has my dialysis stopped? Like just basic stuff like that. And, I was scheduled to get this done, but what happens if this person doesn't get this mammogram? How are we going to know? Like, what happens if this person doesn't come in and get their, vaccinations before school start or whatever? Like, we need to figure out what essential care is. And I don't think the American Academy of Pediatrics has outlined it. And if they have, that message has not been disseminated to the community. So pediatricians are like, don't come in. But I'm like, but there are a lot of hands-on things that need to be done at the pediatrician's office, like oral assessment or like a
Yeah.
weight for a 5-day-old baby. So I'm sorry that they're experiencing that.
Yeah, I would agree with that. Anecdotally, I have a friend here whose son has been or child has been battling some type of viral situation for many, many weeks, but hadn't been able to get in to the doctor's office because prioritizing COVID-19, and or maybe if he has it, doesn't want to come and infect anybody. So there's a whole lack of care that is being provided to folks in general. And certainly it becomes acute when you have a newborn at home and you don't know what to do in terms of feeding. You have been sent home with a lot of information.
Mm-hmm.
I am really thankful for, shameless plug. I'm really thankful for the resources that folks like LER are providing, and lots of other organizations have now come on
Mm-hmm.
board as well to provide free handouts for families, free webinars, free, so that providers can get equipped to support the families in their communities the best way that they can. Angela mentioned the website before, LER, lactationtraining.com/COVID-19 is where LER has tons of handouts. We've got one for families in terms of being prepared for a teleconsult. But lots of resources like that are popping up all over the place. Keep your eye out. Stay really sharp as you would anyway to be current as a practitioner. Stay sharp on what's becoming available at your disposal right now that you can share with families to better support them and keep them,
Right.
you know, in touch as much as possible. Make sure that no one's falling through the gaps. No, the worst thing that could possibly happen at this point is on the other side of this, we have families who have experienced loss or failure to thrive babies because they weren't provided with breastfeeding support and couldn't
Yes.
afford other means or couldn't access other means of infant nutrition. And so that would be detrimental to those families, devastating to those families, but also for the entire field. We be set back, right?
Mm-hmm.
Because we know it gets spun as, oh, breastfeeding is not safe, it's not enough, and and so it's imperative for all of us to make sure that we're doing our very best to support these families to be successful now, for many, many, many reasons that are all valid and important.
Mm-hmm.
Angela, you got anything else
Absolutely.
from the field there,
I do. I got a
from the
couple
listeners?
here. So, someone is asking, how can you help with breastfeeding at a distance, either via FaceTime or 6 feet apart?
So we've got
Uh,
handy resources for not
mm-hmm.
FaceTime, but for teleconsults. Please listen to the Q&A recordings that we've done from 3 weeks ago, I think, where we talked about how to
Mhm.
walk through a teleconsult. It is detailed. We've also on the site I just mentioned got a fact sheet that walks you through every minute of a teleconsult. If you stick to that, you will be providing really optimal care in that way. So that's the um, virtually piece. What do you think about
Right.
6 feet, Nikki?
In person, we also talked about this when we did spoke to Jada about how in the hospital, I mean, how they're providing it, and they're using what we tend to do often, but it's more of second next to touching is mirror. You have the baby, a baby in your hand, and they have a baby, and they just you demonstrate through a mirror demonstration, and so have them do exactly what you're doing, and that also works as well. We're going to do the best that we can. We're going to use good hand washing. We're going to provide, and I hesitate to say PPE because like a lot of people just don't have it. Like lactation consultants, when we talk about PPE, we're on the bottom of the totem pole as far as availability of PPE. So get yourself a mask, um, gloves, if you got them. Otherwise, wash your hands, and then use some sanitizer. But obviously 6 feet away, you can't see a whole lot, but get a little close with your mask on, see what you can see, and then step back and go ahead and demonstrate a different way.
Yeah. So I'll put you on the spot, Nikki, and ask you to explain a bit about how you've prepared for your visits today that you're going to do. Um,
Oh,
but first, I'll note that we mentioned that there's also a respectable distance. So it may not
mm-hmm.
be respectable to stay a full 6 feet away. That's why it's important for both you
Right.
and the client to have on a mask. You don't want to come in their
Mm-hmm.
home or in their space and act as if you're afraid of them. That doesn't really set the
Yes.
tone for the type of consult you want to have. And so both of you are masked. That's a really good barrier to protect both you and the client. But also you want to keep some distance, but not so much that it seems as if it makes it uncomfortable. But Nikki, how
Mm-hmm.
are you planning to protect yourself on your visit today?
So I actually like lost some sleep last night trying to wrap my head around like how to prepare for today. Because while like this is my jam, like doing home visits and I can do this all day, like this COVID thing has added a whole nother layer to it. And I was like, if I am thinking about how I did them before, like what am I going to change? So I usually have a bag with me. Now, mind you, I'm going into a homeless shelter. So I'm going from room to room, space to space, so it's not like I don't actually get to sit down all the time. So I usually have a crossbody bag and it has like my blood pressure cuff, all those things inside the bag. And then I have a foldable clipboard that folds out. It's my little board and I take notes. Well, today I have a shower caddy. And in the shower caddy is my blood pressure cuff. We already have a scale at the shelter, which I leave there so they can weigh when I'm not there. It has a blood pressure cuff. It has a box of Lysol wipes. It has a Doppler, which I have to use this time. It has sanitizer and all those things in it. And that's what I'll be taking with me. Now I'll have on a scrub jacket and I have gloves in there as well. I will go see the mom with the new baby first because I have one that has a 5-day old. I will see her first, and then after seeing her, I will remove my scrub jacket, and then I will go see the pregnant folks, which are on the same floor. Uh, that's the extent of my PPE today. Like that is the best situation that I could come up with. Washing my hands constantly in between each person. As I'm doing the exam on the baby, I will use gloves. But I have to get close to this baby. Like I have to be able to smell their umbilical cord. I have to be able to, do these things with the baby. But once I'm finished, like so I see, and then I step back. And I would say my respectable but distance, which for me is like 3 feet, because that's the only way that I can really see what's going on. But I'm taking as many precautions as I can in a space that it has, which is very a vulnerable space.
Yeah, and she'll have a mask on as well, for sure.
Oh,
Will
and
the families
sorry, y'all, I do have a mess.
will the families have masks
Forgiven.
on? The parents that you'll see?
So I don't know. I don't know.
Yeah.
I did one day. I went to the shelter and I just like literally did like a drive by, and they have been providing bandanas for everyone.
Okay.
And she very well may have a bandana, but I also saw some people there that didn't have masks. Now, mind you, this is an open shelter; so they can come and go as they please. So
Uh,
the level of infection could be quite high, just because we don't know anything. Like it's not a closed area where it's very like they're taking your temperatures when you come and go. That's not happening. They just they
mm.
see me, they see Nurse Nikki, they're gonna open the door. So yeah, and the precautions I take when I come home in my backyard, in the shed, my husband has placed bags for me to put all my clothes in, and I come through the back door, go straight to the shower, and wash every part of my body, and then that's what I do. And once a week, I'm going to be going to do home visits at the shelter.
That's what it looks like, folks. Thank you so much,
Yep.
Nikki, for that.
So
Any
Nikki, a
other
quick
questions,
question
Angela?
about
Oh,
that. Yeah, so a question about what you
Yeah.
just said though. So if you are going into a
Mm-hmm.
client's home and you're going into the homeless shelter, but let's say you're going into someone's house, and
Yeah.
of course the mask. So what would you suggest? So mask for the parents, mask for you. What about gloves
Mm-hmm.
though? Besides doing an oral assessment or besides touching, do you think that gloves are necessary when you walk in that door? Why not? Why not?
It's just so gloves. I feel like people have put this value on gloves that just isn't. I find gloves to be impersonal, and it's not really like you're transmitting any type of infection anywhere other than like if you're dealing with body fluids. So I don't actually see gloves as just like you see people around in the grocery store and they have these gloves on and they're touching everything, and then they get in their car with the same gloves on. I'm like, yeah, that's no that's point. Like
that's
just
not how
wash
that
your
works.
hands, and that's what we should be doing. Now, what I will say is the only reason why I wear gloves with babies is because I have nails. And as we know, we can scrub as much as we can, but and I have rings on, so I wear that in patient care sometimes just for that reason. But other than that, like I don't really see the the purpose of gloves if you're not dealing with body fluids. Because that means that you would just be wearing them constantly like your new hands. Are you gonna wash the gloves? So yeah, it's I think it's more of a I think the glove thing has gotten a little out of control and is maybe spreading more stuff than what we need. But if you feel comfortable with gloves in touching the client and then taking them off, just know that you still have to wash your hands. Either way, you have to wash your hands.
Well, but what about if, and so this is one of the questions in the chat, what if you
Mm-hmm.
are in someone's home and every place is a hot spot these days. Every place has got,
Right.
and you're touching their furniture, right? You're touching their
Mm-hmm.
furniture or you're touching that and then so then your hands, so in other words, it would be wise to not touch your face, to use hand
Yeah.
sanitizer before you touch your face, to wash your
Mm-hmm.
hands before you maybe leave their
Right.
house or as soon as you get into your
Mm-hmm.
vehicle or walk out of the house, hand sanitize it in. So you don't need gloves when you're in
Yes.
that space as long as you don't touch your
No.
face, right?
Exactly.
Right.
Exactly. And if you touch your face, wash your face. Like, yeah.
Wash your
Another thing
eyes.
that I used to that I do is I take a bottle of water and I have some soap and in my car like a little thing of soap and I just like there and I'm just washing my hands like
Mobile washing
with my door
station.
open
Yeah.
and I'm just washing.
Yeah.
Yeah, a little washing station. Which is a new thing. I just saw that on Facebook. Like there's a portable washing station that you can carry with a pump attached to a water bottle and it pumps the soap out and then you just wash your hands. Like it's not a bad
Nice.
idea because you go to some spaces. Think about when you do a home visit and you go in there to wash your hands. You're like, the moment I come in, I'm like, oh, I'm gonna wash my hands. You go in there and then they have a towel, and I'm like, is that
Mm,
a towel that you want me to wipe my hands on? So now
yeah.
I take my own paper towel to people's houses. I'm like,
Yeah.
I'm not drying my hands on what you
Same.
dry your whatever on. So,
Right. Well, thank you for
so
that
yeah.
comment on that. I just want to let people know because someone else has asked questions about PPE for lactation
Mhm.
consultants in this setting, and I just want to say that we are actually working on that content now, and there should be another fact sheet probably within the next several days that will be coming out. I would say early next week. So
Okay.
do know that that is a topic that we too are getting content for to make sure that the suggestions that we make are spot on. So thank you for that information.
So fact sheets are free downloads, y'all. Free downloads coming your way. LER
Free.
is
y'all coming away with a whole curriculum
Yeah,
of how to
yeah.
do telehealth.
Well, this is
So keep
this
it
is
on
what we
our
need to
site.
do, right? When we go looking for
Yeah.
something and we
Oh
can't
yeah.
find
Oh, for
it,
sure. I just want them to
it's
see the
good.
value
It's
and
good.
all of this
Yeah.
stuff. Yeah.
Right. So someone else is mentioning here. So now we've got all these really. I'm just putting you on notice here. Okay, there's some challenging
Uh-oh.
situations in here. So take a breath.
Okay.
What do you do about? And this person has written several comments. Premature infants
Mhm.
discharged home and being directed
Mhm.
to offer express breast milk with powdered formula as a fortifier. When families
Mhm.
can't afford formula and want to wean from the fortifier, there's no frequent weight checks due to no in-person visits. What algorithms, guidelines do you use to transition to exclusive breastfeeding? This person is saying also local food banks are low to no formula left. And when I asked, when is the pediatric provider recommending a follow-up, they're saying at a month. And some of this person's clients have been told to breastfeed on one breast and then do one bottle feed with fortifier with no direction for weaning and just telling them to sort of wean eventually.
Mhm.
So
Wow.
any comments? Take a moment and breathe. I do want to say, put a plug in for USBC, United States Breastfeeding Committee, is actually collecting stories around COVID.
Yes. Yes.
This
Mhm.
is a story that must be heard. And there are stories from both parents and providers, and all of us who are struggling mightily with these exact scenarios. So, what would you suggest for this family who wants to wean from the fortifier, is having a challenge with those frequent weight checks? Any comments?
I have a
Hmm.
comment.
Go
I have
for
a
it.
Isn't it a shame that we can't tell people their providers are idiots? Isn't it a shame? That's my comment. But sometimes it feels really appropriate to say that is asinine advice that you've been given. But yeah,
Right.
yeah, I digress. Sorry, Nikki, you probably have something sound to offer.
I do not. But I would say this. I have been approached with a situation before COVID where there were triplets. They were all on human milk fortifier in the hospital, and then they came home and they were transferred over to um, non-human milk fortifier. And they weren't accepting it well. They weren't tolerating it well. They were vomiting and all these things. I'm like, y'all didn't do a trial of this in the hospital. Like, how are we supposed to know this was going to work? And so we took them off. And they got breast milk. And I said we monitor their weights, and I made them. They got a scale, and they did it that way. One of the things that I would say is the doctors, like, if this child is truly failure to thrive, which a preemie, when I hear of a preemie on fortifier, that to me failure to thrive, like they have a risk of failure to thrive. That is a nursing diagnosis. Um, they need to be seen more regularly. And the doctor has to be pressed. They're like, actually, this child needs to be seen. These other kids, if they're term, great, that's fine. You can put them on telehealth. But this kid right here, they need to be seen by the pediatrician. And so there's a press, and they can't like really say, hey, we're not going to see this. We refuse to see this child. No, this child is a preemie, and they're on a fortifier, and we need to make sure their weights are up to date. And once I know that we have a weight, then I can wean the fortifier, because with that, they can slowly start saying, oh, well, one a day, we're not giving the fortifier, and see how it works. Another time we take it off, and not, you decrease the amount of fortifiers they're getting, but also you need to have a mechanism in place where we're looking at a weight. Also, this is where I'm really finicky about weight, because this child needs to be seen in order for this weaning process to occur. One can't happen without the other if we don't know what's going on with it. Yes, we can look at diapers and all this, but this child can slip so easily because they're a preemie. I don't take that chance. The pediatrician definitely needs to do their job and see this child, because this is a high risk patient. Not high risk COVID, not a COVID. So that's a high risk patient also. But this is a high risk patient. The high risk patients that we used to see, that we prioritized before COVID, they're still high risk patients now. So we have to, that's what I'm talking about, essential care. This is essential care. This child has to be seen by a provider. We can't punt this to telehealth.
I would agree. I would agree. I think this is also a really important time to stay in communication with the parents to understand what it is they're prioritizing, what's important to them.
Right.
They may be okay with certain aspects of this, although
Mhm.
I'm not.
Okay.
But
Right.
make sure that you are honoring what their wishes are and what they're most comfortable with, while also educating and supporting them through this.
Mhm.
That's a key component that we can't
Yeah.
overlook.
Care
Well,
plan.
and
This is persons on a care plan that we update all the time.
and I also want to just comment as well, when a baby is discharged on a fortifier, one of the questions that I will empower parents to say is to ask the pediatric provider why. Is it weight? Is it magnesium? Is it calcium? Is it what is the reason for that? And then I've been known to contact the pediatric provider myself and say hi. Parents really, and just to lay out the situation, just lay it out and say, you know what,
Mhm.
parents really want to wean from this. Parents are having a really hard time finding formula. How can we support this family? We all want this baby to grow and to thrive. What can we do here? And so really, I think some of the pediatric providers may find it's just sort of a knee-jerk reaction to discharge on fortifier
Mhm.
without having that sort of cogent care plan for stepping down
Right.
from that, and what are the parameters that a baby needs to meet in order to for everyone to feel safe that it's okay to slowly start and slowly back off. So that's good.
Mhm.
Great point. Good
And
point.
so last comment here, there's like two here, but let's end here. One of
Mhm.
the last comment has to do with offering for a hospital-based lactation consultant,
Mhm.
and they have, let's see here, they're in Florida. Families being discharged after 24 hours, right when the infants start to wake up and start to feed normally. Our prenatal classes, breastfeeding support groups, and postpartum support groups have all been stopped at this time. Lactation consultants are
Mm.
being redeployed. Keep breathing. And these families are following in between the cracks.
Hmm?
The person then turns around and states, when I said, are the providers able to offer telemedicine? Have you heard of other lactation consultants who are doing support groups in other ways? And they're saying, I have not started telemedicine. There has been talk about it, but lots of, quote, red tape. I'm one of the RNIBCLCs that have been redeployed from that hospital. So I've started doing telehealth and will be working on starting free virtual support groups through their private practice. So what can you suggest? What can you suggest as far as filling that gap? Because the one thing I find is that lactation support providers are some of the most compassionate people I know. And so what are some things that you can suggest here?
Well, I feel like they've done quite a bit in terms of already making the decision to, hey, I'm going to support these families from my private practice. This is, there's a need. I'm going to make myself available to the community. Did I hear that right?
Yes, you did, yes. And also I
Okay.
think in the context of that self-care as well. So, but what can you
Mhm.
do to support these families? And let's, speak to that.
Yeah. So I would say to continue to just to employ some of the things we've talked about over the course of this call and some previous ones, which include finding the families. I hope that the hospital might be open. I would hope that they'd be open to allowing you to reach out to those families or allowing you to advertise your services to those families so that they know that you are
Mhm.
available, and hopefully that is not considered a conflict of interest. If you can, then that's your in, right? That's your way to make sure that they are not falling through the cracks. At least you have the one opportunity to touch bases with them, right? When you do so, then I think that figuring out what makes the most sense for your community is important. So for some, that may be, virtual support groups where you get a lot of people on Zoom and you all meet together and you try to get these families kind of go through this journey together as a cohort. That is really powerful in some places. Other places, one-on-one is where it happens. You can set up a situation where you're seeing them in person. Nikki's talked about what that looks like now as we're starting to get cities opening up and people coming into each other's spaces. Certainly, in some cases, there's going to be a need to do that to see babies in person. We just can't handle everything virtually. And the hospital may not be a resource to them. but do what makes sense in your area and what's comfortable for you, what you are able to carry as an individual. To that point, self-care means creating boundaries. That's where I would start. What do you think, Nikki?
I agree, absolutely. I think, the hospital is missing a huge opportunity to provide preventative care. And I think a lot of hospitals are doing this in that they're so bogged down or so focused on secondary and tertiary care that we forgot to prevent some stuff. We forgot our preventative care measures, and breastfeeding is one of those things. We want to prevent these babies from getting sick. And so they're repurposing, for lack of better words, out of the IBCLCs to other spaces. So you have a niche, like you have a private practice. Say, hey, a few things can happen. One, you can reinstate us because our breastfeeding numbers will go down. And if you're baby friendly, shame on them for doing that. And number two, like they should reinstate you. Number two, you can say, hey, can I have access to these clients? Or number three, like you can create a contract with my private practice and we can provide these services based on, and we can give you some data from that to show breastfeeding rates, and we can share that data between the two organizations. Because do you really want your breastfeeding rates to drop like that and you to lose those coins? Probably not. So we have to kind of challenge them and say this is a part of the care in which we've always provided on a plethora of arenas. So we have to make sure that we're keeping that up, because how are you going to ramp this up afterwards? Like how are you going to bring back lactation after, and what are you going to, how are you even going to represent it afterwards? Like what is it going to be when this is the time for us to be really strong and have continue, growing as a department when you repurpose lactation in other ways. So
Questions that need answers. And if you pose it that way, then they see, oh no, this is probably bigger than I think.
right.
If you kick the can down the road a little bit, you see what's going to be happening next year this time. I don't want to set myself up where I have, this is the organization speaking. I don't want to set myself up where I have taint us in terms of breastfeeding rates because of this pandemic. So position it in a way that the organization, the institution feels as if they can benefit from continuing to support families through you.
Sounds good. Thank you. All right. I think that's good. There's a couple more comments here, but I think we'll go ahead and answer them either in the next call or we can answer them on the website. I can type in, for those of you who maybe still have another question or two, I'll go ahead and type into the chat my email address. And so Nikki and Nikki can move on with the rest of their days as I see little people saying hello. So thank you. This is it, right? This is it.
It is.
So thank you both so much for offering, for providing so much information, so much care, so much support. Thank you both very much.
Thank you, Angela. Thank you, Lactation Education Resources, for making it possible. We do. Thank you. See you next week.
See you next week.
Be well, everyone.